And as I said, yes, last week, and I'll say every week, this is a very horizontal kind of network where we're all working together because we know our environments better than anyone else. So hopefully some of this is transferable, but please do share so that we can all reflect. This week we're going to add a new dimension to the session, which is adding some polls. And Nick is going to hopefully make this a bit more interactive. So last week was a little bit didactic, and it was kind of a background to antimicrobial resistance in children, antimicrobial stewardship, bits about the pipeline for antimicrobials. And this week we're going to speak about the bioflora, what organisms we have inside us as human beings. We're going to talk about when friendly bugs become less friendly bugs. We call those sort of pathogens, and the role of antibiotics. And Nick and I are going to share this presentation. Nick's going to talk more about the antibiotics and their actions and things, and I'm going to talk more about the bugs and a bit about the spectrum of antibiotics. But let's start with a case. So hopefully you can see this picture, and this picture is of a girl called Delilah, who's 5 years old, and she, like many of the children managed in our children's hospitals, has got global developmental delay. And as I said last week, the face of paediatrics has changed markedly over the last 15 or 20 years, from what used to be acute paediatrics, where you'd get a load of bronchiolitics in and children with rotavirus and all sorts, to a brave new world of chronic comorbidities, chronic respiratory neurological conditions and cerebral palsy, and children with seizure disorders and all sorts. And this is one of those sorts of girls who has a peg in situ, because to get her calorific intake up, it's not adequate just with oral feeding, so she has a peg in. And she's presented because she has a fever and a leaking gastrostomy, and she's otherwise well, with some coryzal symptoms. And we said last week that cultures are very important. You've got to get a sample. And so the district nurse had been to a session that someone had given on taking good samples, and had meticulously taken a sample that has grown a bacteria called Staphylococcus aureus, which hopefully some of you have heard of. And I appreciate there's a wide mix of people within our infection teams. We've got microbiologists who clearly know a hell of a lot more about Staph aureus than I do, to people that probably know more about delivering high quality patient care to frontline patients, and less about the actual bugs and the drugs. So that's why we have infection teams, where we're all bringing our expertise to this. So my question is, what would you do? And hopefully Nick is going to produce a poll somehow. Nick, is that what you're doing, or?
Yeah, there should be a poll up.
Okay, and I think it's because I've got a funny view that I can't really see what's happening. Can other people see a poll, or it's in the chat?
Yeah.
Okay, people answer it, and then if people start answering, there are a few options. I think one is reassure with supportive care and antipyretics. The next is start some oral flucloxacillin. I'll explain that flucloxacillin later in this talk is a very effective antibiotic against SSA, so Staph aureus that's sensitive to methicillin. You could give a topical antibiotic like topical fusidin, which is another very good staphylococcal agent. You could stop the use of the PEG and give IV antibiotics and request a surgical review, or you could refer to the gastrostomy nurses for some silver nitrate. Nick, what are people thinking? You're on mute.
So about half of people have voted to start flucloxacillin, and then the other half is split between reassurance and supportive care and topical fusidin.
Good. Well, that was absolutely exactly what's nice is that there's a split of votes. That's why these polls are quite interesting. And I think this demonstrates a really important point, which is understanding the normal flora of the body is really important if you want to interpret microbiology results. And what's important with this case is that if you swab most people's skin or shove a swab up their nose, you may well grow Staph aureus. And yet, if that had been a very different looking sort of infection with pus coming out, with cellulitis spreading, being painful, that would be suggestive of an infection. But I think what you've got in this situation is it's very hard to interpret the Staph aureus result. And that Staph aureus result is clearly there is Staph aureus there. That goes without saying. You've grown it on your plate. But whether this reflects colonization, so whether that's just your bioflora or whether that's infection, is the decision you need to make. And in my opinion, and in the opinion of our kind of peer gastrostomy toolkit, which you could find on the peer guidelines, you wouldn't be treating this for infection because there is no evidence of spreading cellulitis. The child has a fever because they've got coryzal symptoms. They've not got fever because they've got rip-roaring cellulitis or a collection under there. That would be significant pain associated with that. And even in a child with cerebral palsy who may not be able to communicate well, they would still exhibit the physiological metrics of pain if you press on something. And there's no, so the answer here would actually probably be reassurance. You may give some silver nitrate as a barrier, but essentially reassurance would be the appropriate treatment. But the point is not what you answered. The point is understanding the concept of microbiota, and those are the bugs that are within us. I think it's important to just play the numbers game here. So we have a lot of human cells. I'm not going to get you to count how many cells you've got in you, but it's a lot. It's about 10 to the 13 cells. So that's 10 with 13 zeros after it. If you actually counted up all the microbial cells in your body, microbial cells is bacterial cells plus others, but predominantly bacterial cells in your body, you've got more bacterial cells than human cells. And so that can't be done by accident. There has to be a reason why we've got so many bacterial cells within us, and that's because that mix of bacteria clearly helps with certain processes in our body. And I'll come back to that in a moment, because meddling with our microbiota, which is those microbial cells, those bacteria within us, or the microbiome, which is the genetic content of all of that microbiota, should be done in the knowledge that it's a perilous thing to meddle with it if you don't need to meddle with it. And I think we can get a bit of an understanding of what this microbiota business is. And when you look at babies, and clearly babies are born in generally one or two ways, which is either vaginally or by cesarean section. And you don't have to read anything on this slide. And I'm assuming you're not colorblind, and it's not red and green, it's red and blue. So you should be able to see a distinction. You'll see that a baby born vaginally has a very different makeup of bacteria compared to a baby that's delivered by cesarean section. And it takes a good number of months for a baby that's born by cesarean section to have the same diversity. And you'll see a lot of blue, and a lot of that blue is kind of gram-negative organisms. It's gram-negative and gram-positives, actually, staph and streps. But you have very little of the bifidobacterium and things like that in babies born by cesarean section. And what that means is unclear. I mean, but it's just that your diversity of organisms is very different when you're born vaginally. And the relevance of that is about the importance of skin to skin. It's the importance of breastfeeding. If you can implement all of that as early as possible, you're more likely to have a more biodiverse and protective bioflora than if you don't. And clearly, if we gave that baby that was born vaginally antibiotics on day 0 or 1 of life, which about 15% of babies in your hospital probably get. And if you did do a survey or an audit of early onset sepsis treatment, it was up at 15% for us for a number of years. It's now down at about 7% because of some of the Kaiser Permanente and things we put in place. You would see a totally different color chart as soon as you started those antibiotics, and you would totally skew away from that lovely biodiverse flora. And the reason that that's relevant relates to this concept called the microbiome. So the microbiome, you may or may not have heard, but as I said, it's the kind of the genetic makeup of all of that, those microbiological things in our body that numerically are greater than our human cells. And we know that antibiotics are growth promoters in animals. And we know that because people that are livestock farmers have historically given their animals lots of antibiotics, not just to protect them from infection. They do that quite effectively with vaccines, but actually to make them fatter. And when you then look at the fat distribution of these two mice, mice on the right-hand side, you see that the lower mouse has been exposed to antibiotics after, in the infant period when it was a baby mouse, and its fat composition is far greater than the one that wasn't, which is interesting. It gets much more interesting when you try and work out why that happens. And it's not directly because of the antibiotics. I mean, clearly the antibiotics have an impact on something, but when we actually take the stool from those two mice, one of whom was exposed to antibiotics and one who wasn't, and we put them into antibiotic naive mice, baby mice, we just transfer the stool and thus the microbiome. The stool that came from the mice that had been exposed to antibiotics results in a far fatter mouse than the one that wasn't, and that's that red box there is totally different. And so there's something about what we're doing and meddling with the bacterial composition of bodies, especially when they're young, so especially in infants, that has a potential market impact on things. And those things can be obesity, but they can be more than that. And I'm not going to talk through this in a lot of detail because it's just association data. It doesn't tell us that it's definitely causation, although that mouse data is clearly causation data, but it's not human. But we see, and this is a big population from a town in America done a few years ago, followed up for a number of years, that children who are exposed to antibiotics in the first 2 years of life are far more likely to end up with long-term conditions related to obesity, related to atopy, allergies, asthma, celiac disease, and all sorts. So I think that it's really important to recognize that we have a lot of bacteria in our body, and one of the harms we do with antibiotics, especially in young children, infants, neonates, is meddling with that. So, I go back to this bit about the Staph aureus. You think back to that case, we identified Staph aureus, and when you look at what the normal, you need to know what's normal in different bits of the body. And on this picture, you can see on the skin, you commonly have Staph aureus, you commonly have Staph epi. That's a cons. And for any of you that do blood cultures and you get a cons result in a child that doesn't have a central line in situ, you realize that that's generally a contaminant. And the reason that's relevant is that if you didn't know that Staph epi was normally on the skin, say if it wasn't normally in the skin and then you got it in the blood from a blood culture, well, that wouldn't be a contaminant. So knowing what is normal and what's in the different bits of our bodies is really important when it comes to interpreting microbiology results. And then when you look at the nasopharynx, you commonly have things like strep pneumo. You often have group A. You may have group A. That's group A strep. Is strep pyogenes. You might have group A strep. You might have strep pneumo. You might have Haemophilus. You might even have Neisseria meningitis that's up there. Often have some Staph aureus in your nose, the others were in your throat, and often they sit there harmlessly. And we know that the rates of colonization with these sorts of bacteria in young children is extremely high, and often it causes absolutely no problem. So when you get a group A strep in a throat swab of a young child, it can be, or strep pneumo, say, it can be very hard to interpret because it doesn't mean that it's actually causing any problems. So just be mindful how you interpret that. And it has to be done in partnership with the clinical phenotype, a bit like that first case where if you had spreading erythema, high fever with no other cause, significant pain, well, then you would buy into that being a pathogen as opposed to being a commensal. And in the mouth, you get anaerobic streptococci and other anaerobes. You get things in the GI tract. That's where you get all your gram negatives, as well as your anaerobes, your Bacteroides and things. So, and that's relevant because when you then get a contaminated urine specimen, well, it's going to be contaminated with stuff from the vaginal tract or from the GI tract going to the vaginal tract often. And so that's why when you get a mixed gram negative and a urine sample, be mindful of how you interpret it. And actually, let's go on to this case, which is sort of that situation. So you have a urine sample taken from a febrile toddler. We know that toddlers are highly likely to have UTIs. And when it's febrile, we take it seriously because we think it might be an upper UTI, pyelonephritis. And this child had a fever. It wasn't an obvious focus. It wasn't they had a big runny nose and cough and a respiratory tract infection. So very sensibly, the ED doctors took a urine specimen, and that urine specimen was dipped, and dipsticks are good, and it was positive for leukocytes and protein. And subsequently, the culture was sent to the lab, and the culture comes back with a result of Enterococcus faecalis, which is a gram positive that behaves a bit like a gram negative, and some E. coli with certain amounts. And the question, the questions that you need to ask yourself when you're interpreting it, whether you're a hospital home nurse or whether you're a pharmacist is doing a review of the antimicrobials, or whether you're a pediatrician, or even whether you're a microbiologist, is actually, is this a pathogen or a commensal? And so the questions I have for you, and people can, I don't know if we're going to do this as a poll, but as a free chat poll or something, Nick, or if people just write in the chat, what would you like to know in order to interpret this result? What sorts of things are going to help you decide whether you give this child antibiotics or not? And Nick, if you sing out some of those answers as people are typing them, that would be super helpful. Or you don't have to sing them out, you can just speak them out, actually. That would be fine.
So we've got questions about what's the child's CRP. Libby wants to know how, or two people want to know how we've got the sample. So was it a clean catch? Is it from a catheter bag? Clinically, how's the child? Are they still febrile? Have they got an abnormal USF? Have they got previous UTIs? More about how is she clinically? What are observations? Any other clinical symptoms?
Yeah, all very good questions. All very good questions. I think I think how the specimen was collected is super important. I think the other bit is what else is on a urine strip? It's not just leukocytes and protein. There's white cells on there. Did this child have any white cells on there? If you've got no white cells in a non-oncology, I mean, clearly, if you have no white cells because you're on chemo, then you're not going to mount white cells in the urine. But it's very hard to have a UTI without white cells, leukocytes. But clearly, we've got leukocytes in the urine, but we'd like to know on the microscopy potentially as well. I think the bit about how was the specimen collected, is it a bag? Is it a clean catch? Is it an in-out catheter, is super important actually. And in the and epithelial cells is actually often quite useful as well. If you've got a shed load of epithelial cells in there, it's giving you a flavour that this might be a contaminated specimen. So there's a little bit of data about contamination rates in young children. I mean, we clearly don't use bags. The only time that people sometimes use bags is if they get a bag sample and it's totally negative on dipstick. That's highly predictive of it not being a UTI, actually. The risk there is that something's on the dipstick and then you send that specimen and then you're completely pickled, because it's going to be highly likely to be contaminated and you're likely to get a culture result like this. And that was what happened in this situation, actually. This child had because they were running around and no one seemed to be able to catch a urine, they whacked a bag on, they then got a dipstick hoping it would be negative, it was positive, and someone then just sent it off, and you're completely pickled. You have no idea how to interpret that, and you then need to collect another specimen. People collect clean catch specimens. I think that is the appropriate thing to do in this child. I think in our younger children who are, under 6 months, under 3 months, I'd really recommend doing an in-out catheter, because in our hands in Southampton, about 50% of our clean catch specimens are contaminated. It's much higher than the published data. And so it's just problematic urines in children. And when it really matters in our youngest children, who will then be exposed to IV antibiotics potentially, I'd really want a good quality specimen. So this is all about the importance of getting a good quality specimen. And the other bit is that just because you isolate something on culture, a bit like that Staph aureus, and it might not just be on culture. Some of our tests, like our rapid respiratory virus tests for flu and RSV and COVID and things, give us an answer. But you've always got a question: is that actually the cause of the symptoms, or is it reflecting, an old infection or a commensal? And so there is an art to interpreting microbiology and virology test results, and interpret them with caution, because you can be misled and you can have actually missed something either far more significant, or in this case, a child just having, 2 days later, they develop a big rash and they've got roseola. So, that was a totally different viral diagnosis on this child, and they never had a UTI at all. And you're right, you can do CRPs, but, sometimes that they're seen. This child looked okay. Someone dipped the urine, took the urine poorly, dipped it, sent them away, saying we'll wait for the urine. We don't think it's positive. And before you know it, this child's been started on oral or IV antibiotics, and it's just a complete mess. And at that point, you don't know what you're treating. So it is important to recognize that normal flora can, the bugs we have on our skin, up our nose, in our guts can cause problems. And those problems usually result when those barriers are breached. And so the time that a cons, coagulase negative staph, or a Staph aureus can cause a problem is when you've got a line in your skin, either a peripheral cannula, and we see that more in adults, but that also happens with children. And there are cases where you get proper nasty invasive infection with a local invasive spreading to invasive disease with cannulas, but often with our central lines, you get a cons and a central line, and that's because we have broken the skin. And children whose guts are playing up, especially children on chemotherapy with mucositis, you get translocation of gut bugs. You can get translocation from the nasal tract to cause brain abscesses. And you can get gut flora causing UTIs. So, but that's often when we have done something in terms of disruption. But once again, interpreting these results, it's much easier to interpret a sterile site sample, such as the blood. And even in situations like that, you get contamination when you don't clean the skin properly, the hub of the bottle and all sorts. Harder to interpret non-sterile site cultures like skin cultures because they will naturally have organisms on there. And then you really do need to go on the clinical phenotype. And the UTI, the urine is similar. If you contaminate your specimen because it's a bag or even a clean catch specimen, then it can be challenging to interpret that. And I think the other problem is, and this comes back to how antimicrobials, is that it's obviously you take pneumonia, so pneumonia might be because you are infected with that bug, a strep pneumo from a child. The child is infected from another child in nursery, or group A strep, say. But it might be that bug was just sitting in their oropharynx as a commensal, and then they get a viral infection like RSV or influenza, and that results in a secondary bacterial infection because their respiratory tract allows that bacteria to then become invasive. And the problem we have is that if those commensals are all sensitive to antibiotics, when it's more straightforward for them treating that secondary bacterial infection, when we've exposed them to a shed load of antibiotics, either unnecessarily or necessarily, well, then you have a higher chance of those bugs that have gone from commensals to invasive pathogens being resistant. And so that's kind of why the harms of inappropriate antimicrobial use land directly with the patient who's been exposed to the antibiotics unnecessarily. And we is not only by putting in lines and things and starting cancer treatment do we increase the chance of commensals becoming invasive infections, also just by giving antibiotics, because that you give antibiotics and then you massively increase the chance of those other non-bacterial or resistant pathogens multiplying and having a selection advantage. And that's where our fungal, our thrush, either oral thrush or urogenital thrush comes in when you give them antibiotics unnecessarily. So lots of, it's often our doing. And the other bit that we do is when we admit them to hospital and we don't put appropriate infection prevention practices in place because people don't wash their hands, or they transfer infections from one patient to another because they don't isolate the children that need to be isolated. And that results in, one child's normal flora becoming abnormal flora in another because the child that's now got it from the other one has just had surgery, and it results in a wound infection with MRSA or a resistant gram-negative infection. So lots of reasons for that. So let's move to another case. Sam. Sam is a 2-year-old boy. And this is quite timely because many of us are seeing these kinds of things at the moment. He presents to your assessment unit with fever and shortness of breath. And on examination, you auscultate and you see that he's got some respiratory distress. You listen, he's got some wheeze, widespread wheeze. I say no creps, he might have some creps as well. He's got creps and wheeze because we often hear the two together. And as seems to happen with many children, even if they're not being admitted to hospital, they have some kind of PCR for viruses, or in some situations, a much broader panel if you're using the BioFire. And that it's sent almost as a routine. And fortunately, this child improves. He has some bronchodilators, and he's discharged home with a plan to wean his bronchodilators, and he's thought to have a viral-induced wheeze, which clearly is his diagnosis, and he's not sent home with antibiotics. And then interestingly, when that result, the swab result comes back on the biofire, it's RSV positive and it's also positive for Streptococcus pneumoniae. So the question I've got for the group is, what would you do with that information at this point? Would you go, it's just colonizing, we've heard this talk from Sanjay, we're not going to give any treatment. You're going to call him back or call the GP actually and say, look, we saw this child, strep pneumo's come up. That's a nasty bug. We know it can cause pneumonias. Could you prescribe this child 3 days of amoxicillin? The new NICE guidance is for 3 days for community-acquired pneumonia. Or do you call the family and just see how the child's going? So, Nick, if we could either post that or give us a flavour if people have written A, B, or C.
We've got about 3/4 of people have picked C, call for a welfare check, with the remainder saying it's a colonizing organism that doesn't require treatment.
Yeah, I think
no
that's
one has picked B.
Brilliant. And that's really, it's really good that this sort of message about colonization organisms is clearly sunk in already, and people are recognizing that interpreting, they're not black or white, these results. These are just a bit of the jigsaw, and the other bits of the jigsaw are the story, the examination, the response to the treatments you've given. I think many people have, see microbiology results as very black or white and feel an obligation to act on them. And I'm glad that no one has acted blindly on that, because I think just phoning the family and checking this child doesn't now have high fever and increasing respiratory distress and is becoming more unwell. If they were, you'd need to get them back and you'd need to examine them, and you need to potentially do a chest x-ray and start them on antibiotics, and oral antibiotics would probably be fine. But clearly this child continues to improve and they just had a viral induced wheeze. Well done. Excellent. So let's do a very quick sort of update on pathogens. And once again, I appreciate that some people in the audience have got a lot more knowledge of pathogens than I do. So for those of you, bear with me, and for the rest of you, hopefully we pitch this about right. So, irrespective of who you are, you could be a hospital home nurse, you could be a paediatrician, you may get a phone call from Christina, who's in the group. She's one of our microbiology colleagues in Hampshire hospitals, saying this. Sanjay, I've got this gram-positive coccus from a blood culture. And at that point, that's really important information. But to some extent, you need to understand what that means and how that influences your reflection on what treatment the child has been on. And clearly, this is likely to be within 24 hours. 48 hours, whatever, 24 hours of the blood culture being taken. So this child may or may not even be in hospital at this point. Or they might ring to say a gram-negative bacilli in the urine, or they might even say a gram-negative diplococcus seen in the CSF, which I think would generate more alarm than maybe some of the others, or great alarm anyway. And so, this is all important because you've very sensibly taken the correct cultures on these children. But depending on this information, you might be able to act and do something that might benefit the patient, either by changing their antimicrobials or checking they're on the right antimicrobial. And so it's, for many people, it's been many years since they've thought about bacteria, and I really want to focus on gram-positive and gram-negative bacteria. And just as a by the by, talk about atypicals, which are things like mycoplasma. They're a bit different and they don't really have great cell walls. They're very hard to culture. Or anaerobes, things like C. diff, Clostridium, which really like oxygen. They love to grow when there is an oxygen around. But the majority of the pathogens, so the bugs that cause problems in children that we see, are either gram-positives or gram-negatives. And some of those anaerobes, they also fit into gram-positive and gram-negative as well. So let's talk a little bit about that and what the difference is. And I'm just going to sort of skim over this. I think the important bits are the colour of these two pictures. So that's gram-positive and gram-negative. You'll see that's a purple colour for gram-positive and that's a pink colour for gram-negative. This is only of interest to me. I think the majority of people on this call will not be looking at gram stains. So you'll just have to believe what your microbiology colleagues tell you when they call. But there is a fundamental difference between these two types of organisms, and it relates to their the outer membrane or their cell wall. So both of them have cell walls, but the gram-negative organisms have an extra layer outside of that, an outer cell membrane that's made up of this thing called lipopolysaccharide, which is a lipid, a sort of a fatty layer, which in itself can cause great problems because it can sort of aggravate the immune system quite severely and cause a sort of a shock-like thing related to lipopolysaccharide. And these are a few more colors and shapes. You'll remember the purple relates to gram positives and the pinks relate to gram negatives, but you'll see a slight difference in shape. If you look really squint at this, you'll look at some of the things that what look like circles, like grapes. So that's purple, so it's gram positive. It's circle, so it's cocci, and it's in clusters opposed to chains, whilst the thing below it is more like comma shape, so that's a gram-positive bacillus. And so once again, this isn't hugely relevant for any of you, but it is relevant with relation to that phone call. So when Christina calls you and says there's a gram-positive coccus in the blood, that immediately tells you that it's going to be either a staphylococcus or streptococcus. So when she says that it's in clumps like this one, it's really pushing you towards it being a staphylococcus. That doesn't still tell you whether it's a Staphylococcus aureus, which is clearly very bad in the blood, or a coagulase negative staph, which may be a contaminant, but it's a huge amount of information just from that very small amount of information that you've been told gram-positive coccus in clumps. Whilst if you're told there's a gram-negative coccus, and that's a much rarer sort of phone call, but that was what was in the CSF on the slide before, and that would really suggest the Neisseria meningitidis. So that would be meningococcal meningitis, and you'll get an ID on that. We'll talk about that in a moment. Whilst if you got that other phone call about the urine and it was if you got a phone call about the urine, it was the gram-negative bacillus, and that's all of our E. coli, our Klebsiellas, our Enterobacters, and we call those the Enterobacterales group. There's a big group of bacteria that look quite similar, or it could be a Pseudomonas or a Haemophilus, which are also gram-negative bacilli. And we won't say too much more about gram-positive bacilli. That's C. diff and things. And why does any of this matter? Well, as I said, the microscopy is useful because you get a massive load of information about just whether it's a gram-positive, a gram-negative, and whether it's a bacillus or a coccus. The next step, so what happens in the lab, and this might be a few hours or a day later, it's that information will hopefully be translated into a name of a bacteria. So just by looking at how it grows, so it gets taken from the blood and it gets scraped onto these agar plates, and just by the look and the shape of those colonies, you get a lot of information about whether it's Staph aureus or not. And then what will happen is potentially it will go into some kind of machine that might identify it, and we won't talk so much about the different machines or chemical ways of identifying different organisms, but that's what the lab does, and it does it hugely efficiently. But the other bit you want to know, and this sometimes takes a bit longer, is actually which antibiotics is that bug susceptible to? Which antibiotics will kill the bacteria that's causing the problems in my child? And that's what we call sensitivity, susceptibility testing. And that's when the bug is put on a plate with those discs on. Those discs each contain different antibiotics, which then permeate into the plate. And clearly, if the antibiotic kills the bacteria, you end up with a lovely clear area. If the bacteria can grow right up to that disc, it's telling you that the antibiotic would not kill the bacteria, and that would be regarded as resistant. So there are different ways and genetic ways of getting information about the susceptibility of bacteria to different antibiotics. So, you don't, unless you're a microbiologist, you don't need to know much of this, but it is important because it gives you a flavor of the timelines it takes to get culture results, then get an ID and identification, and then to get susceptibility testing. This does not happen overnight, as in it, you won't get all of that very rarely in a 6-hour period. And so, just thinking about patients, and a patient comes in with a skin infection, your choice of antibiotics is very different to the choice of antibiotics you give if a child comes in with a urinary tract infection, because you need to know what the likely bacteria are that cause that clinical phenotype to decide what the best empirical treatment. And empirical essentially means guesswork, an educated guess, as opposed to targeted treatment, which means you've gone through that process on the previous slide where you've cultured something, you've identified it, and you've got susceptibility testing. And so our gram-positive, like our staphylococci, Staph aureus, and streptococci, group A strep, will be common causes of skin infections, bone and joint infections, and chest infections. So our Streptococcus pneumoniae will often cause chest infections. Staph aureus may as well, group A strep might. Whilst our gram-negative infection, so that's skin and bones on those arrows. Whilst our gram-negative infections, so these are things that are often harbored in the gut, are more likely to cause our gut infections, things like salmonella, things like shigella, etc. Toxigenic E. coli will cause urinary tract infections and may cause some chest infections as well, like Haemophilus, etc. Pseudomonas in comorbid children. And then our anaerobes tend to affect the gut, either the upper end of the gut around the mouth or the bowels, and also abscesses. So an appendicitis, where you've got a perforated appendix, that the anaerobes live in your gut along with lots of your gram-negatives. And atypicals, as I said, things like mycoplasma, but generally cause very few problems in children. And I think that we overplay the role of atypical infections massively in children, and we shouldn't be routinely covering for atypical infections. And we may talk about that in a future lecture. Nick, I think over to you. I can tell me when to change the slide. So we'll talk a little bit about antibiotics.
Yeah. So what is the right antibiotic to give in these situations? And I think simply the right antibiotic will get to the right part of the body, and it will kill the pathogen with as little effect on your natural microbiota, and with minimal like ADRs on the rest of the body as well. Next slide, please, Sanjay. And just to highlight that, so what do we mean by the right part of the body? So sensitivity reports, when you read them, they don't necessarily differentiate between different parts of the body. So it's important that the antibiotic isn't only effective against the bacteria, but it also gets to the site of the infection. And so when we're talking about the blood-brain barrier, for example, gentamicin doesn't really readily cross the blood-brain barrier, and vancomycin doesn't do a very good job when your blood-brain barrier is still complete, but when your meninges are inflamed, you get a bit more transmission. And that's actually the same for many beta-lactams. A lot of beta-lactams don't actually have great penetration of the CNS when the CNS isn't inflamed. It's only when you've got that meningitis that you get better penetration. And because of that, that's why we have CNS doses of antibiotics, because we need that higher plasma level to push the drugs across the blood-brain barrier. And then when we get into the kidneys, so as I'm sure many of you know, nitrofurantoin won't treat a systemic infection, because it needs to be concentrated in the urine for it to be above the MIC of the bacteria in the urine. And that's also why for nitrofurantoin, actually, in poor renal function, you wouldn't give it to treat a UTI because it's not actually filtered effectively into the urine at poorer GFR. So, and again, just another one would be caspofungin. If you're using that to treat like candidiarrhea, only about 1% of caspofungin makes it into the urine. So even if you'd had a fungal susceptibility testing to caspofungin, there'd be no point using it to treat a fungal infection of the kidneys or urinary tract. And then into the lungs, as it says there, gentamicin has quite poor chest cover. So if you're trying to cover a gram-negative in the chest, and you've got sensitivity to gentamicin, that doesn't do a world of good to add gentamicin in, especially because gentamicin is quite a narrow therapeutic range. And daptomycin gets entirely inactivated by the surfactant in the lungs. So if you're treating a chest infection with daptomycin, you're not really going to achieve any sort of therapeutic levels, which is why for chest infections, you see we use beta-lactams more certainly our favorite beta-lactams, like amoxicillin, piptaz, benzopenicillin. A lot of the penicillins do get into the chest very well. Next slide, please. So the next thing is it needs to kill the pathogen with as little effect on the bacterial flora as possible. So this means using an appropriate spectrum of antibiotic, but not just an appropriate spectrum, but also an appropriate dose. And this is why we have empiric guidelines that Sanjay touched on earlier. We don't just try and sort of bleach every patient that comes through the door. If we've got a chest focus, then we use that antibiotic that we know concentrates in the chest. If you've got a urinary focus, then we're trying to focus on the urinary tract. And they might be local empiric guidelines, or that might be following what UK PAS has to offer. And then once you've got sensitivities, can you narrow down with those sensitivities to again minimize the effect on bacterial flora, or potentially could you stop antibiotics altogether, reducing the actual exposure that the flora have to antibiotics? And that sort of depends on positive or negative cultures, and if you've got any other tests like virology to rule in or out. I think that's everything that I've got to say.
Yeah, thank you. And thinking back to what you just said about caspofungin, it just reminds me how important it is to work with your pharmacy colleagues, because some of this stuff is really difficult to remember. And although guidelines are good and they sort of talk about some common presentations, our pharmacy colleagues have just got this wealth of expertise with things like where these antibiotics work and antimicrobials, antifungals in this case work. So, really good that you were able to talk through that, actually, Nick. Thank you. So important at this point to tell everyone that we will be sharing these slides. And that's because this is quite a detailed, complicated slide, and it contains a vast amount of information. But we start off with gram positives, gram negatives, and anaerobes on this almost Mercedes-like sign. And what we're going to go through is the spectrum of different antibiotics. And once again, to reiterate that broader is not necessarily better. And actually, often our best antibiotics are our narrowest antibiotics. And so everyone reaches for the blunderbuss and meropenem, but actually that's not perfect and it's not brilliant for certain infections. And so you are much better off thinking about where the infection is, what the likely pathogens are, and going for a targeted antibiotic. And so let's take a bone and joint infection, say, let's take osteomyelitis. You know that it's likely to be a staph or a strep. In a 7-year-old, a 10-year-old, it's going to be Staph aureus or a group A strep, but probably by far most likely to be Staph aureus. So what do you treat them with? Well, actually, or if you've got a C. diff, we won't talk much about that, but if you've got a child with a UTI, which is going to be an E. coli, Klebsiella, or you've got a child who's known to be colonized with Pseudomonas, who now comes in with a nasty lower respiratory tract infection, or if you've got someone who's colonized with a resistant, and we'll talk a little bit about ESBLs and AMP-Cs, but essentially say that they're just resistance mechanisms for gram negatives, which just mean that some of our common antibiotics don't work. But in light of all of this, you need to have an approach to which antibiotics to start and what different antibiotics cover. So for gram positives, so you've heard, everyone's heard about penicillin, you've heard about amoxicillin, and I've heard about flucloxacillin. So flucloxacillin is one of our best antibiotics against Staph aureus. It's very narrow, and it's not, as you can see on this diagram, it's not covering any of the gram negatives, it's not covering any of the anaerobes, but it's giving you really good cover against MSSA, which is one of the commonest bacteria that we have to manage in children. The other big player for pathogens in children is strep pneumococcus. And actually, one of the best antibiotics, the best antibiotic you can give for that is benzyl penicillin or amoxicillin. As you can see, really narrow. It might have a little bit of cover against some gram negatives, but once again, a pretty narrow spectrum antibiotic. And the reason I say it's narrow is when you compare it to some of our first generation cephalosporins. So this is things like potentially some of the cefalexin, etc., or you compare it to coamoxiclav. These are much broader, and the broader is good when you don't know the bug, or if a pneumonia is potentially being caused by a whole variety of different things, you might go, oh, okay, I can give co-amoxicillin because it will cover some gram negatives and gram positives, but actually so does amoxicillin. And that's why my previous graph wasn't quite right. It should have had some gram negative cover. It should have some Haemophilus cover often as well. And the danger of broad spectrum is it has more of an impact on your microbiota, and then it skews your microbiota and increases the risk of selecting out resistant organisms. So the things that aren't being covered. And the more you knock out, the smaller the remaining pool is that can then divide and divide. And so augmentin is good because it covers gram negatives, it covers some gram positives, lots of gram positives, and it covers some anaerobes as well. Then you go to drugs like tazocin. Tazocin, most people have heard of. It's often used in febrile neutropenia as first-line treatment. And the reason for that is it's very broad spectrum, but it also covers Pseudomonas. So the difference really between coamoxiclav and tazocin is essentially tazocin offers Pseudomonas cover. You then go to drugs like meropenem. Meropenem is like tazocin. It covers gram negatives very well. It covers gram positives reasonably well, but it overcomes some of the resistance mechanisms that we are increasingly seeing, especially in children in other countries like Greece, Spain, India, Russia, Middle East. So if you've got a child coming over from there who's really sick with a likely gram-negative infection, you may decide that meropenem is an appropriate empirical treatment, especially if they are septic. But you have to understand why you think it's appropriate, and that's because that relates to its ability to overcome some of our common resistance mechanisms. And it also offers some anaerobic cover as well. So meropenem you very rarely have to give with something like metronidazole. And as I say, metronidazole is a very good drug against anaerobes. So you might see kef and met being used. That would be kef-uroxime or kef-triaxone and metronidazole, because that's covering your gram negatives as well as anaerobes for a gut infection. Vancomycin people have heard of. It's a very good gram positive cover, but it also overcomes MRSA, methicillin resistant Staph aureus, and then gets more complicated with our complicated gram positive infections where you need drugs like linezolid or daptomycin, which we're not really going to touch on today. I think by that point I'd be knowing about the child, and they're not drugs that would be routinely started unless they're advice from a microbiologist or a peds ID person. And people have heard about ciprofloxacin and gentamicin and amikacin, and these are very good gram-negative agents. But once again, especially cipro can be quite broad spectrum and drive resistance. And as I want to reiterate, breadth does not equal strength. And my favorite antibiotics are often the narrowest agents. But it's only when a child is really unwell and you're not sure what the pathogen is, you might go broader in the knowledge that your empirical treatment can then be targeted when you get a pathogen and sensitivities. And that's what this concept of start smart then focuses. It's that you have to evaluate how likely a bacterial infection is, how likely the child is to benefit from antibiotics, and put your patient factors into the mix as well. How likely are they to, how predisposed are they to a bacterial infection? How likely are they to deteriorate significantly if they have a bacterial infection? And also how likely are they to harbor a resistant infection? And that might be looking at their previous microbiology to see what they've got. And with all of that information, the first thing you still want to do is take appropriate cultures, do appropriate tests like CRPs. And many of you asked for that with that child with the urine result. I thought that was a very sensible thing to ask for. A normal CRP would essentially rule out a pyelonephritis, rule out a significant invasive bacterial infection. And then you decide whether they did antibiotics, and you'd go to the UK PAS or the Wessex empirical guidance to give you an idea once you've made a diagnosis of what appropriate empirical treatment is. To be clear, that guidance just doesn't take into that many patient factors. So although it may say flucloxacillin for a bone and joint infection, if that child has recently arrived from a hospital in Dubai or in Kuwait, then you may need to speak to your local microbiologist or peds ID person to decide whether this child falls outside of the guidelines and whether you need to have a more tailored approach until you've got more information about that child. And then the 2 time points that are important are what you do at the beginning, that's the start smart, and then what you do when you've got some investigations and a bit of observational history, observational data at 48 hours. And that's when you decide whether actually with that added information, and the culture results that the child never had a bacterial infection at all, or whether you've got a Staph aureus that's sensitive to fluclox and you've switched them to that, or whether they can be ambulated, or whether it was a highly resistant infection and you need broadening of antibiotics. So that's the approach of how you use clinical data and microbiological data to focus your decision making about antimicrobials at 48 to 72 hours. And then, what is the right antibiotic? We said it needs to kill the pathogen with as little effect on the rest of the body, and that's because many of antibiotics, they confer side effects, adverse drug reactions, and things like gentamicin that we commonly use. We're increasingly realizing we have to be careful with because of its impact on ototoxicity, and that's some thoughts about what might be introduced in some places or in the future about how can we screen for babies that are most susceptible to hearing loss associated with aminoglycosides. Nick, pharmacodynamics.
Yeah, so when we're talking about the sort of action of antibiotics and the pharmacodynamic, there are sort of three major pharmacodynamic indices that we use. And the first one here is Cmax, which is the peak concentration over the minimum inhibitory concentration. And the MIC being sort of the minimum concentration of antibiotic you need for it to exert its effect on the bacteria. And classically, we would refer to this as the aminoglycoside, so gentamicin. But the other thing that we need to consider with these as well is actually that many of these drugs have a prolonged antibiotic effect. So, for example, gentamicin, aminoglycosides, and quinolones, they have quite a prolonged antibiotic effect. And these tend to be the drugs that target sort of bacterial machinery, so drugs that attack things that produce proteins and nucleic acids. These take longer for the bacteria to generate. And so actually the time above MIC for these drugs isn't as important as really getting that dose in. And that's why we quite often, if you've got poor clearance of gentamicin, that's why we prefer to extend the interval rather than reduce the dose, because getting that peak is really important. The next sort of one that we'll talk about is time above MIC. So this is classically beta-lactams, our penicillins and our cephalosporins. Really important with our penicillins. So we started using much more extended and continuous infusions in PICU and NNU with our beta-lactams. And that's because here really what's important is actually the time that the antibiotic in the body is above that MIC for it to exert its killing on the bacteria. And there's recently in the last few years been shown that even small changes can have quite a dramatic effect pharmacokinetically. So only a couple of years ago, actually, we used to bolus piperacillin, tazobactam, or tazocin, and it's been shown that actually changing this to even a short infusion over 30 minutes provides quite significant pharmacokinetic superiority to the bolus. And there's actually been two recent adult papers come out in 2024. The Bling-3 paper, which was investigating a prospective trial investigating continuous infusions in adults of beta-lactams. And that showed a non-statistically significant benefit clinically, but did show a pharmacological or pharmacokinetic benefit. But the authors were quite keen to point out that the confidence intervals did actually include a sort of a clinical benefit to extending the beta-lactam infusions. And another paper that came out in 2024 was a big retrospective meta-analysis that showed actually in intensive care patients, again, this is adult data, but actually using continuous infusions resulted in clinically significant improvements in morbidity and mortality at 90 days in these critically unwell adults. So there is certainly evidence to show that we should, in seriously unwell children, be optimizing their pharmacokinetics with these beta-lactams, stop bolusing them, and in the really, really unwell ones, and endocarditis, we've been using continuous infusions. This is also important in OPAT services. It's much more common in adults of complicated bone and joint infections. and tricky to treat Pseudomonas. They get 24-hour infusions under these elastomerics, which we have started using in children, but it's a little bit more complicated because, as you know, we don't have standard doses. And that's why in impaired renal impairment for beta-lactams, you'll notice that the majority of the dosing ends up being reducing the dose rather than increasing the interval. Because here, actually, it's important that we keep the blood concentration above that MIC for as much time as possible. And I think it's about 50% for penicillins to be effective and about 70% for cephalosporins to be effective, which is actually why a lot of cephalosporins we don't dose reduce very often at all. And then the last one is AUC of MIC. Here, dose adjustment's a bit more flexible because in theory, if you give the same dose once a day versus the same dose or half a dose twice a day, you get a very similar AUC over MIC. And drugs that fall into here are quinolones and vancomycin, macrolides, and clindamycin as well. So for vancomycin, this is why there's a bit of a mixed cohort on it. The start of reducing doses, we would keep with the same dose, but increase the interval. But actually after that, we start thinking about reducing the dose, and that's because there's a lot more flexibility compared to Cmax or time above MIC pharmacodynamics. And importantly with vancomycin as well, time is quite an important factor, the time above the MIC, even though it's AUC MIC dependent. And that's why we are moving towards using continuous infusions for line infections, because it is really important to have that contact time. And if you run the drug through the line and then you flush that line, you're actually not getting that time above MIC where the bacteria is. So that goes back to the right antibiotic concentrating in the right place. And that place might be inside the plastic, not inside the body. So that's sort of the three main pharmacodynamic indices that we use when we talk about antibiotics.
Thanks, Nick. Really good. And just so people are clear, people have probably heard this concept of pharmacokinetics, which is the interaction between the drug and the body. So how it's absorbed if it's orally, how it's metabolized, how it distributes across the body, and then how it's excreted. But this concept of pharmacodynamics is how the drug interacts with the bug. And it's really important because if you don't understand that your beta lactams work on this time over MIC bit, you don't understand the importance of making sure that when you give them flucloxacillin, it really does need to be taken at the times it's supposed to be. Otherwise, it just doesn't work. And that would be the reason for your treatment failure. So, really important principle, pharmacodynamics. So let's sort of wrap up. We've got one last case, which the 4-year-old child who was seen a couple of days ago in your ED, being prescribed penicillin V by their GP 5 days ago because they had tonsillitis. And that's 4 times a day as per the BNFC. And actually, mum admits that he only took about 2 of those doses per day. So this links in with the slide that Nick just presented. So what do you think the likely cause of his initial antibiotic failure is? His initial failure, not maybe what he needs doing now, but do you think that we just gave him the wrong antibiotic, that we just didn't quite recognize what the likely bug causing a tonsillitis was, and penicillin B is not appropriate, that we just didn't get enough time over the MIC? As we heard, this is a beta-lactam, and that's how the pharmacodynamics of beta-lactams work. Whether actually this was viral and this is just normal, just kind of just reassure the parents. We seem to have D twice, so maybe ignore D. E is poor absorption. So do you just think that this is an antibiotic with rubbish bioavailability? It just doesn't, you give it orally, it should have been given IV. Or do you think actually this is to do with antimicrobial resistance, and actually this has now become resistant to penicillin? And Nick, what are people saying?
So the majority of people have picked that it's inadequate time above the MIC. And then we have a smattering of viral tonsillitis, inadequate concentration, and bacterial resistance.
Yeah, and I think all of that, that's right. Tonsillitis, we often use things like fever pain. It's a good scoring system to give us an idea of whether it's like to be group A strep. I think the problem now is that this child has probably got something a little bit worse, and has now got a hot potato voice and might actually need some sort of drainage because they might have a quinsy or something. But yeah, if you give penicillin V is quite a complicated antibiotic, and I know it's recommended by NICE and it's in the BNFC, but it's variably tolerated by children and it's 4 times a day. So often for our local guidance, we use amoxicillin. We might use amoxicillin twice a day. It's really important that you give an antibiotic, and this has to be a suspension. There are only 4 that tastes okay, and taste is important. We'll talk about that in another session. And so, if his throat, if he didn't have what appeared to be a quinsy or something, um, what would you do? Would you this is a bacterial tonsillitis. This is like to be group A strep. Obviously, you fever pain him. That would be it. Would you just continue penicillin V? Would you just try and compliance counselling? Really say just go for it. You've got to get it in your child. Would you switch to amoxicillin? Would you switch them to clarithromycin, or would you actually just say you've had enough antibiotics? Your body will do the rest. Nick, what are people thinking?
Most people are switching to amoxicillin, with some doing some compliance counselling, and one person is going to switch to clarithromycin.
Yeah, I think I think that don't trying to push this with penicillin V is difficult. This family have tried really hard, and I think although we can all be purists in terms of antimicrobial stewardship people, we have to be pragmatists. If a child needs antibiotics and you think they're going to benefit from it, you've got to use an antibiotic that you can get into the child, and that's one that tastes okay and is ideally not 4 times a day. So I would switch to Amox. I wouldn't switch to Clarithromycin. There's no reason to. It's probably not as good, and it tastes even worse than the penicillin V. And I do think this child needs antibiotics. So yeah, pragmatism versus purism, I think, is really important in pediatrics, because we do need to, you know, get these things in there, and some antibiotic suspensions taste awful. So I think we might wrap up there actually. The things we spoke about the microbiota, the microbiome, it's diverse, and actually a diverse microbiota is protective against pathogens. It's when you skew it that you allow certain things, often pathogens, to then outgrow other things. And if you mess with your microbiome, you may have long-term impact on things like asthma, obesity, etc. Interpreting microbiology results, it requires some thought. It's not a black or white, it's an art. And that is a part of a jigsaw, including the clinical phenotype, inflammatory markers, the story, where the sample was taken, how it was taken. The cause you get from microbiology, you can get a lot of information even early on, but it takes a bit longer to get the full information. Well, you need identification and sensitivities. Understanding the breadth of antibiotics, the breadth does not equal strength, is important. And often the harm, the collateral damage from your very broad spectrum antibiotics need to be balanced against needing that for certain patients. Pharmacodynamics and understanding that beta-lactams is all about the time above the MIC. The MIC is the minimal inhibitory concentration. It's the minimum amount of drug you need in the blood to stop growth of a bacteria. Having that above that line for as long that level for as long as possible is how beta-lactams work. And we've got to be flexible, just listen to family, work with families, because otherwise, treatment failures happen mainly because people can't get antibiotics in. Okay, thank you. I wonder if there are any questions. I'm going to stop sharing if I can. I know we've run over by about 5 minutes. Sorry. Questions, comments? Well, look, thank you all for interacting. It's really good to have the polls. Nick, first and foremost, thanks to you for organising the polls. I think they work really well. I